Hi everyone, welcome to ResearchHenry.com. My name is Pramil Cheriyath. I'm a physician. I work as a program director, internal medicine residency, transitional residency. I teach medical students and medical residents on. I've been doing that for a long-term basis, and I'm also assistant professor of medicine to large medical schools. So we've been doing a morning report series. Please join us today. So let's start.
So, a 68-year-old male who presented to the emergency room for evaluation of back pain.
Okay, hold on. 68-year-old female.
It's a male.
It's a male. Complained of back pain. All right, let me write it over here. So let me underline this, see what's the most important. So anytime we have something, any situation, what's the first thing I would say?
Emergency.
Rule out emergencies. Okay, very, very important. That's my first step, right? Because the amount of time I'm wasting, 2-hour H&B, and then I found out there was an emergency, you cannot take that time back, right? So always kind of rule out emergency. What are the emergencies in this situation? Somebody come with the back pain. Somebody told me, what are the emergencies?
Abscess.
Abscess, okay, it's an emergency, but okay, I would say, yeah. What else?
Actually, cord compression.
Cord compression. That's an emergency. Somebody come with the back pain. My goal is to make sure there is no cord compression, because if you miss that, what's going to happen? Patient is going to be paralyzed. You don't have. That's So how do you manage cord compression? You call surgery, give IV high dose IV steroids. Right. Those are, you have to do that right away. Right. So that's very important. What else is important? What else is important? Malignancies are important to you, right?
Yes.
Pathological fracture and all those kind of things. What else? Infection, you already said, like an abscess and all that too. What else? Anything else important? I guess anytime somebody is older, if they're on corticosteroid, those are there's something called red flags, okay? So the red flags is very important. So first thing always do to roll out the red flag, okay? Now we come up to, so when we look at, it's already a red flag. What is that red flag in here? 68-year-old, right? Older age people come with back pain. You have to think about it's a red flag. It's very, okay. Now when we talk about, let's see what is the definition of the back pain, or like classification, right? How do you classify back pain? Somebody told me they could be acute. Okay, if it is acute, usually 4 weeks, and then chronic is greater than 12 weeks. Okay, and subacute, something in between, which is what? Between that, like between 4 and 12, we can say subacute. Remember, it's a classification a lot of times, but you have to know the numbers, okay? So somebody tell me acute, how many weeks?
4 weeks.
Okay, and subacute?
Between 4 to 12 weeks.
4 to 12 weeks. And then chronic?
Chronic is more than 12 weeks.
Okay, now tell me about this thing.
Yes.
Tell me about it. So we'll write, let me just write acute, subacute, or chronic. Okay?
Yes.
All right, proceed.
So the patient stated.
Before that, why don't we just talk about broad differential diagnosis of back pain, and then we'll come back to that. Let's talk about broad differential, okay? And let's see. It's a big topic. I mean, everything, if we can. Differential diagnosis is very, very important. It's good to have like a broad differential tile, and then we'll come back with our diagnosis. So first thing I would do, the back pain, I would say any mechanical causes. Okay, somebody told me the mechanical causes. Trauma. Okay, what else? What else? Maybe like spinal stenosis, right? We can put it in that category, right? Even cauda equina, can you put it in here?
Yeah.
It's a mechanical kind of compression, right? What else?
Prosthesis.
Huh?
Spondylolisthesis.
Spondylolisthesis is okay.
Any fractures?
Very good. Fractures, vertebral fractures, right? Like usually the older ladies, you have like, L1, L2, those kind of fractures kind of very important. Huh?
Muscle strain.
Muscle strain also, which is kind of trauma and muscle strain we can put like together, right? Muscle strain. What else?
Herniated disc?
Herniated disc. Very common, right?
Yes.
Herniated disc. Anything else we missed? Sometimes, you can put the piriformis syndrome, like it's somehow examination like that. But there's a compression of like sciatic nerve, so that can usually have buttock pain and kind of pain radiating back pain to do that. So an examination wise, like, I mean, it's not very common, but it will be an examination question with the piriformis syndrome. Let's put that over here, okay? And everybody knows that like piriformis muscle and its sciatic nerve kind of go through that and it get compressed. That's a distribution, the pain, okay? What are the other categories can we can? Let's look at the next one is for like infection. Okay, so let's put infection, right? What are the things in the infection? Somebody tell me louder.
Abscess.
Abscess, you already said that, very good. What else?
Osteomyelitis.
Osteomyelitis, right? We can say discitis. What else?
Pot spine.
Pott's disease,
Yeah, pots.
right? What is that? Somebody tell me what exactly. It's a very important examination question. What disease is it related to?
Tuberculosis.
Tuberculosis. That's very important when you have patient like where they've been living, their social status. Don't assume just because somebody from a different country, a third world country, automatic assume he got TB. Okay, a lot of places, a lot of people in the United States, the population also is susceptible to TB, right? What kind of people? People in jail, those kind of things like drug abuse and all that's very common, okay? Don't categorize people. What else in the infection? Anything else? What about male? It's like prostatitis,
Yeah.
right?
Yes.
What about female?
Pyelonephritis.
PID, you can say, yep, pyelonephritis, endometriosis. Okay, all of those female organs kind of inflammation also can show up. Okay, so we talk about the mechanical, so we talk about the infectious causes. Now, what is the inflammatory? Okay, let's talk about the inflammatory causes. Inflammatory, what are the inflammatory causes?
Ankylosing spondylitis.
Ankylosing spondylitis, okay. What else?
The pain.
Huh?
Yeah. So pain. Psoriatic arthritis.
Okay, you got a mnemonic?
Yep.
Okay, tell me the mnemonic again.
Pain. PAIR.
PAIR. Very good. Sometimes it's going to give us like in the mnemonic and give you the like, you can remember like a little bit easier. So if you find a mnemonic anywhere, please use it constantly, but it kind of stays in our memory. So P start with the psoriatic arthritis, right?
Yes.
We'll put psoriatic arthritis. Okay, A probably ankylosing spondylitis.
Yes.
Okay, very good. I,
IBD related.
IBD related, inflammatory arthritis. R is reactive arthritis, right? These are all very important questions. Ankylosing spondylitis, usually also with the buttock pain. Increase, that is the one like you have pain usually like kind of lasts more than 45. And what is the classic x-ray like bamboo spine and all those kind of things, right? Reactive arthritis, usually the question is like, patient had like a infection before and many diseases you can have. And how do you treat reactive arthritis?
Treat the constipation.
No, you don't treat the cause agent. And mainly like you can give NSAID. You will never find a culture or identify the causes unless it's a sexually transmitted disease causing reactive arthritis. Okay, so if it is a sexually transmitted disease, reactive arthritis, then you treat it with a specific like antibiotic and all that. Otherwise, like anti-inflammatory agent is the one because board is going to ask you about reactive arthritis. So we talked about that. Anything? What is the other major category?
Neoplastic.
Neoplasm. Very good. So neoplasm, like what kind of neoplasm? Somebody tell me.
Spinal mets.
Spinal.
Spinal mets. Okay. What else?
Myeloma. Multiple myeloma.
Multiple myeloma. So what kind of mets? I think it's important to the metastasis to the spine. Like what disease? Somebody tell me faster.
Lung and breast.
Lung, breast, and male
Prostate.
prostate. Okay, remember that lung, breast, and prostate. That's you need to know when you talk about. When you talk about back pain, always look multiple myeloma. It's very, very common in these people, especially elderly people. It's very, very important. Remember that? Okay. So what else? So we talk about multiple myeloma, right? Any other category we can talk
Vascular.
about? Vascular causes. Let's talk about vascular. What are the vascular causes? Let's start with the big one. Even like, let's say triple A, right? What else could be the vascular
Spinal
causes?
epidural hematoma.
Spinal epidural hematoma. Okay, what else? Any kind of spinal infarct, right? Anterior spinal artery, spinal infarct. Those are the most common vascular, okay? And then let's put the other miscellaneous causes like referred pain. Can we say that? Right? Referred pain. What are the major thing we can talk about?
Nephrolithiasis,
Renal stone,
renal stones.
okay. Can an MI be, right?
Yeah.
Let's say the MI, like a PE, those kind of thing also, like, the pain affected and all those kind of thing and also. It's also radiation. Okay, let's hear about this presenting complaint in detail. Now, we just talked about all the differential diagnosis, very, very important. So what is the presenting complaint?
Yes. So the patient stated the pain began 3 weeks ago and has been intermittent since the onset.
3 weeks of pain. Okay.
Yes, and that has been intermittent
Yeah.
since the onset. The patient described a dull pain that increased on inspiration.
Increase on inspiration, right? That's
Yes.
kind of strange. Have you ever, back pain is usually kind of shooting down to the leg. You say increase on inspiration. Is it some kind of fluidity component? I was just kind of worried what's going on. Okay, what else?
So the patient did not seek medical treatment initially because he thought the pain was from his daily activities.
Okay,
The patient works as a truck driver,
as a truck driver, okay.
and
What else?
his trips are usually local and last from 1 to 3 hours.
Okay.
The patient reported right leg pain and swelling.
You also have right leg pain?
Yes, and swelling.
Okay.
And
Right leg pain and swelling. Okay.
patient recently returned from trip to Florida by plane.
Florida trip.
Yes, and today
Mm.
the patient decided to come to the emergency department
Okay.
after the pain has been worsening.
Okay, well now let's look at now I go back and look at my differential diagnosis, because most of our diagnosis we get from the history itself, right? So it's very important to put a history together to get our diagnosis. Okay, so what do you think in your differential diagnosis? What is the most common cause of back pain? You usually have a disc herniation, right?
Yeah.
And then when we look at it, remember every symptom I look at the likelihood ratio of the symptoms. So which, again, I'm trying to roll out cauda equina first, okay? What is the symptom which give you highest likelihood ratio of cauda equina? Anybody know likelihood ratio?
Incontinence.
Incontinence, but not like, urinary incontinence you can say, but the best thing is
Referred
you
pain.
do an ultrasound. If you look at the urinary bladder, and if it is greater than 500 ml urine in there when the patient come in having back pain, that's a very bad sign. That means the likelihood ratio is around 16, okay? So let's say somebody come to the emergency with the back pain, probably the prevalence is like less than 5% or less than 2%, right? So if you add the 16 to it, right, this means my probability of having cauda equina syndrome is extremely high. It'd be like 35, 40 to 50%, right? It's very high. All of a sudden, so that's why you always use positive likelihood ratio in your diagnosis, okay? So main thing we just wanted to make sure there's no cauda equina. So always ask. You didn't say did you say there's no bladder bowel incontinence? No, right? That's those kind of questions you need to ask. Very, very important, because you can rule out a lot of diseases. You have to know the symptoms which give you highest likelihood ratio. Which one is urinary, bladder incontinence is very important. If you do it, there's more than 500 ml in the urine, likelihood ratio is almost 15. So you're also having something like cauda equina go up to 50-60%. Remember that. Okay, so tell me a little bit about it. Usually the back pain is something kind of related to the spine, mechanical kind of cause. But this patient have something to do with the inspiration, right? And something you also have like a right leg pain and swelling, and you went to Florida trip. What do we have to worry about when right leg pain, Florida trip? Is it a DVT?
DVT.
Right? So it's also kind of maybe something, two separate things. I don't know at this point, but both of them need to be investigated, and I have to take it very seriously now. Everybody agree that?
Yes.
Okay, maybe it's a two different thing, or maybe it's a combined thing. I don't know. We just have to be careful. All right, past medical history.
Past medical history, the patient has hypertension and
Okay, what kind
diabetes.
of past medical history before we need to know? What kind of past medical history we need to know? Come on, somebody.
Any
We need a
malignancies?
malignancy, yeah. Okay, what else? What else we need to know?
Any use of steroids?
Osteoporosis or any kind of previous history of trauma, those kind of things we need to know. Okay, the observation, past medical history, ordinary cyclical hypertension. Okay,
Yes.
what about, do we need to know about surgical history in this patient?
Yes.
Why is that? A lot of people have back pain, have surgeries, like tons and tons of surgeries now they do for back pain. Orthopedic make millions of dollars on like back pain people, right? So they have like disc surgery and all of that. So it's always important to ask them, did you have any surgeries in the back and all that too? Okay, so you didn't have any of that. So let's go to the medication. Why is medication is important to you? What medication the patient is on first?
The patient is on.
Is he taking any pain medication?
No, he's not.
Okay, so what is important to you? Two medications which is a red flag. Somebody tell me, what are the two medications a red flag?
Steroids.
Steroids. If the patient is on corticosteroid, that is itself a red flag, can have infection, a lot of complications. What else? What's the other one?
Anticoagulants.
Anticoagulation. They can have spinal epidural hematoma is also very common in this
Drug
group. So
abuse.
you have to,
Drug abuse.
Yeah, drug abuse, which will come back to that. So we have to, that's why we have to know the medication history, right? And then let's talk about the social history. Does he smoke?
Yes, he's a smoker.
Why is the smoking is important? Malignancy is
Yes.
important, right? Does he use alcohol?
Yes, he drinks 1 beer per day.
1 beer per day, okay. What else?
Uh,
What else in the social history we need to know? Like, we already said, he said like drug abuse, right?
Yes.
Because IV drug abuse, then abscess is very common, discitis, osteomyelitis, and all of that's very common. So it's very important to ask are they using any recreational? You don't ask, are you doing cocaine? And have you ever used any recreational drug? And those kind of questions you have to ask, okay? And then we can talk about, psychiatric history and all of this you have to do like a very thorough. Now let's go back to our examination, right? Vital signs. Somebody give me the vital signs.
Patient's blood pressure is 138 or 79.
Uh-huh.
Temperature is 99.
Mm-hmm.
Pulse is 114.
Uh-huh.
Respiratory rate is 20.
Uh-huh.
Saturation is 93%.
93%. Okay, what does this tell us? Somebody tell me. Like, what are the abnormals in here?
His pulse, heart
Yeah,
rate.
now is tachycardic,
Yes.
right? Now, what could be the tachycardia? Especially like I know we said like if there's pain, there's tachycardia, right? And then he could also have leg swelling or is it DVT and tachycardia, right? What else is wrong over here?
Respiratory rate.
Is also, respiratory rate is okay, but I'm surprised there is like a 93%. Those are the two things kind of worries me in this, right? Can I link those with this one? Of course, right? If somebody have like DVT and tachycardia and hypoxia and pruritic kind of similar to the picture, recent travel, I need to worry about what?
Pulmonary
Embolism, I should be like worry about it, okay? Now, what do you find in the examination? Anything?
Not significant. Everything is.
Examination, and what kind of examination is very important, especially the neuro examination, right? What are the neuro things we need to do? First of all, did you do straight leg test racing in this patient?
No.
Why is that? Somebody with a back pain, right? And if you don't do even a straight leg test, that kind of tell me you did not take this case very seriously. It's very important part of somebody with a back pain, right? So make sure you don't miss that. You have to be like very, very careful, especially when you present something like that. Okay. What about anal examination, neuro examination? Is there a sensory level? That's what we're looking for, right? Is there an absence of anal tone? Is also important. Rectal examination also is very, very important. This patient, right? You need to look for malignancy. Those kind of things is important. Or like, or let's say if there is tenderness on the spinal area, then that means like an infection, fracture, or malignancy when you press it. That's also kind of very important to know on examination, right? And then what else? Did you tell me about the range of motion? Did you check for why do we need to check the range of motion? Okay,
Yes.
so you have ankylosing spondylitis, you already said, and all that too. And also, I always try to look back and see the patient have like scoliosis, any of those kind of like the cause and pain. Those are the main things. Scoliosis, like okay, don't so just do systematic. First, you look at is there any mechanical changes like scoliosis, that kind of thing. Do a neuro exam, right? You do a straight leg testing. You look for like a rectal tone. Those kind of things is very important. Okay,
Yeah.
now. What are the labs? Before we go, what labs are important to you? Why should we like only the labs important to me? Tell me, ask, and all of you have to tell me what labs you're going to order. Rather than like if you are an incompetent clinician, what are they going to do? Do a millions of tests, millions of imaging, and don't even know what's going on. I have like I have a practitioner used, I think it was a whole body scan, and everything kind of light up and asked me, what should I do? Don't make the mistake. Be very specific. So what labs are important to me? Somebody, let's start with the CBC. What are we looking in the CBC for?
Infection.
Infection. So WBC is important,
Yes.
right? What is a WBC?
11.
Yeah, WBC is slightly elevated. What else is important in the, do we know hemoglobin is important to us?
Mm.
Is it like anticoagulation of the
Yeah.
hemorrhage and those kind of things is important? What's the hemoglobin is important?
14.
14, okay. Platelets important again, like bleeding and all those kind of
Yes.
things we did. Now, what's the platelet?
195.
195. Okay, so we talked about CBC, let's talk about the BMP. So we'll just write the BMP. Is sodium important to us? Somebody come on.
No.
Okay, SIADH, right? What's the most common hyponatremia is SIADH in the United States. Could it be caused by malignancy?
Yes.
Right? What type of, like, can it be like lung cancer?
Yes.
Right? Could it spread to the spinal region?
Yes.
Spinal
Yes.
mets, right? You already said, like, somebody told me, like,
Paraneoplastic syndrome.
okay, paraneoplastic syndrome, but again, like, one of the mets go to, like, prostate, right? Lung cancer, breast cancer, you already told me that. So that can also cause, like, what type of lung cancer cause, like, SIADH and
Small cell carcinoma.
small cell
Small
cancer, remember
Yes.
that, okay? So sodium, what's the sodium in this
Sodium
patient?
137.
Uh-huh,
Potassium 3.8.
uh-huh,
Chloride 106.
uh-huh,
Bicarb 22.
22,
BUN 18.
uh-huh,
Creatinine is 1.10.
1.1. Okay, what was the blood sugar?
Was 160.
160? Okay. So, I think another thing in this patient is 22. Every lab value we need to put together and try to learn from it. There's so many things. So, anytime 22, what does that mean? Somebody tell me.
Metabolic acidosis.
Metabolic acidosis. What's the next step you have to do? What do you do when somebody metabolic acidosis? What do you have to do?
Check for the gap.
ABG.
Anion gap. See, somebody said ABG, arterial blood gas. That's the most wrong, incorrect answer. If you order ABG, and if I'm rounding with you, you're going to be gone. Why is that?
Because
ABG costs a lot of money. First of all, you're puncturing the artery, you're putting the patient in danger. Okay? The first step is not ABG. Okay? Remember that. Don't say that wrong answer again. I get really upset when people say that. Nothing wrong with it, but you have to learn from it. You got it?
Yes, from
Say it. I will not do ABG first.
I will not do ABG.
Okay, so what's the first step you have to do?
Anion Gap.
Anion gap. So when you see a metabolic acidosis, you do an anion gap. You have to find out is it a non-anion gap or anion gap. Is it an anion gap or non-anion gap?
137 minus 128.
Yep.
Non-anion.
So it's a non-anion gap metabolic acidosis. I put NAG. Okay. Now I have to link this. Come on, somebody, if you tell me all this differential diagnosis, which one give you non-anion gap? Like I'm talking about non-anion gap. What is the normal? Is it correct? First of all, it's a non-anion gap metabolic acidosis. What is the anion gap in this patient?
9.
9. Anion gap is 9, right? So let's look at it. The normal is between around 12. So we got a low anion gap. Okay? So low anion gap. Which disease in this, all the differential diagnosis, which one we have to kind of link? Somebody get an award if they can link all this. One disease we can link with a low anion gap. Not much. Somebody come on. Let's see who's the smartest person in this. No? Multiple myeloma. Okay. So you got multiple myeloma. Where is the multiple myeloma here? Right?
Malignancies, yes.
Is commonly associated with a low anion gap, right? Can multiple myeloma cause back pain, right?
Yes.
Like fractures and all that kind of thing is very common. Okay, remember, at least one point you learned today, right? Anion gap, we always talk about high anion gap and all that too. This is not normal. Normal is around 12. This is a low anion gap metabolic acidosis, not high anion gap metabolic acidosis. Everybody got it? Okay, so what else? What are the other labs we should check? Come on, somebody tell me what is important.
ESR and CRP.
ESR and CRP, right? We already talked about malignancy, infection, all this differential diagnosis. ESR is important, right? What else would you do? Anything else? Multiple myeloma, what's the other lab you should check? Common.
IgG, IgM.
That's all like, coming back to this. I mean, calcium level, right?
Yes.
Hypercalcemia. Hypercalcemia associated with malignancy,
Yes.
right?
Yes.
Okay, so just to check the calcium level, that's what's important. At least one step at a time. Multiple myeloma, you don't order all this million IgG and all those kind of thing, okay? So it's very important to know all of that differential diagnosis, but let's come and compress into a diagnosis and then we order like more other tests. Anything else we need to check in this patient? We know the patient hypoxic, right? We know the patient is had like leg swelling. He has traveled to Florida. He's a truck driver. So we already suspecting a PE. Any markers we can do?
D-dimer.
A D-dimer probably like a reasonable thing, right? Before D-dimer, what I do is like I always check a well score on this patient, okay? So when you check, then somebody calculate a well score for me. Let's look at it like, each point, right? If you have symptoms similar to like a PE, right? What's the first one? Okay,
Yeah,
somebody use the computer and
symptoms-
kind of tell me what exactly the
symptoms
number
of DVT.
of Wells criteria, because I know the symptoms similar to DVT, the presentation. He got leg swelling, right? And then he got like he has traveled to Florida, he's tachycardic, he's hypoxic. So what is the number?
4.5.
4.5, okay? So we know D-dimer, we know well score is high, right? So if we want to check, now I know I need to get a CT of the chest on this patient, or imaging, right?
Yes.
It's very important to know, because, well score is high. You
Yes.
can go with D-dimer, even if the D-dimer is negative, I would still get a CT of the chest. So, that's important, right? Okay, and then any imaging on the back would you do in somebody with the back pain? If it is in the outpatient settings, it's not very, not significant, right? If you get an X-ray, what are you looking for? Pretty much some kind of fracture. Like, what do you want to do? With, usually like vertebral fracture, pretty much you give it the pain control, and if you get excessive, then it's like vertebroplasty and all that. So I wouldn't just kind of jump in. Let's say if there's an examination question, an outpatient come in, just automatically jump into imaging. Look at all the causes, like the mechanical causes, okay? In the hospital setting, if somebody come with a severe pain, he's 68-year-old, a lot of red flags over here, then I would do imaging. Most probably like an MRI of the spine. It's not unreasonable, but be careful when you take expensive tests. When you take an examination, all of a sudden you jump in. Most of the time, expensive tests, you're wrong. Okay? Maybe an MRI is fine because already you have like some red flags in here. So what did they do a CT of the chest? What did that show?
Yes. It showed there was right-sided pulmonary embolism.
So you got PE.
Yes.
Okay, so we know there is a PE. Did they do a spine anything?
No.
Okay, so then, I would have done that also. I don't know. Maybe it's something kind of similar to. So any other question we have to do?
Can we do PT, PTT, and INR for
Why
the
is that? It is not on anticoagulation, right?
Yeah.
Maybe kind of later on, only way I can think is like lupus anticoagulant, because if he has a PE, then he had to do like later on. We don't know if it looks like a provoked PV, right? Do you all agree? This is a guy who had been traveling, he went to Florida, he got a leg swelling, it's a truck driver, right? It's not an unprovoked, so I don't know. If it is unprovoked, then I have to think about the anticoagulant workup is
Right.
important. It could be lupus anticoagulant. Then the PTT kind of comes into play. Remember that. Okay, so what's our diagnosis here? What was our number one diagnosis? Somebody tell me. We can say, of course, we can say PE,
Pulmonary embolism.
right? PE, CT positive, right? And then how do you treat the patient? Anticoagulation, right? We start with the Lovenox, probably a good idea. And then don't do extensive testing in this patient. Look like a provoked PE. When you do order this test at this time, with all the things, all the markers will come back like negative. Maybe kind of later on you can do after like 2 to 3 months and all that. Okay. What are the other things we could learn from here? Number 2, I would say, what else?
Saturation.
Huh?
Saturation 93%. So do we need to?
Yeah, but that all come into the PE picture, right? We know well score is high.
Right.
That we already put it.
Yeah.
Like I don't put it kind of separate too. Let's put it on this low anion gap, right? We know multiple myeloma need to be rolled out. But I wouldn't do because I already know the diagnosis. But at least I'll put it there. Okay, so I would not chase, but I would have ordered the calcium and all that. Anything else we need to do? Okay, very interesting case, right?
Yes.
I mean, an unusual presentation of back pain, but if you have taken, I think I'll give you a lot of credit for taking the good history about his travel history, and then leg swelling. On examination, you did not, like a lot of things you missed on the examination. It's the poor examination skills, which we physicians lack. You did not tell me. What did you didn't tell? What did she miss?
Right leg rising.
Huh?
Leg rising test.
A straight leg, she missed that already. She didn't even tell me, like, is this unilateral swelling of the leg? This is the guy who said he had swelling of the leg. He didn't see it, right? Is there two? Both sides kind of compare. So examination, you have to, we all have to get better in examination.
Yes.
Okay?
Yes.
So that's to make a good point. Again, thank you so much for watching, everyone. Please put some comments under this so we all can have a discussion what we missed in this patient or anything else which way we should have addressed. Any other way, any other differential diagnosis we missed, we can try and talk about it. Let's have a discussion. It's great. This case discussion is the best way to learn. Okay. Thank you so much for watching. We'll be back with another presentation soon. If you could please help us subscribe to our channel, greatly appreciate it. It takes a lot of effort from a lot of people over here to make presentations like this. Thank you again.